Orthopedic Board's review course, rotator cuff, muscles, loss of motion, etc. Overview. We will be discussing adhesive capsulitis, osteochromial, pectoralis major, proximal biceps tendon, rotator cuff tears and impingement, calcific tendonitis, and subscapularis. Adhesive capsulitis. This condition is characterized by a thickened, contracted joint capsule. Patients will have dramatic loss of range of motion, and this will be most pronounced with abduction and external rotation and abduction internal rotation. The essential lesion is a contracture of the coracohumeral ligament and rotator interval, which will translate into dramatic loss of external rotation. It is most commonly idiopathic. Associations include diabetes, cervical spondylosis, hypothyroidism, and female gender. Stage 1 is the inflammatory phase. This is the painful stage. Treatment is early gentle range of motion. This is the stage where cortisone injections, anti-inflammatory medications may be more successful. Stage 2 is the frozen stage. In general, there is less pain. However, there is more significant loss of range of motion. Stage 3 is the thawing stage, characterized by a slow, gradual improvement in range of motion. Each stage can last anywhere from 3 to 6 months. Physical examination. It is important to identify which portion of the capsule is most effective. Loss of external rotation in adduction implies a contracted rotator interval. Loss of external rotation in abduction implies a contracted anterior-inferior portion of the capsule. And loss of internal rotation in abduction implies a contracted posterior-inferior portion of the capsule. X-rays in general are normal. You may see osteopenia. It's important to obtain X-rays, however, to rule out other associated conditions or other conditions that may present with dramatic loss of range of motion, such as glenohumeral arthritis or a chronic locked dislocation. The key thing is to obtain a complete set of films, especially the axillary view, which will identify a locked posterior dislocation. Non-operative treatment is the preferred recommended treatment for this condition. Therapy is the mainstay of treatment. In early stages, glenohumeral cortisone injections can be helpful. Anti-inflammatory medications, physical therapy, a well-structured home exercise program. Long-term problem associated with this condition is residual loss of range of motion compared to the contralateral shoulder. For those patients that fail non-operative treatment, surgery, specifically an arthroscopic capsular release along with a manipulation under anesthesia, is what is recommended. You can see here a arthroscopic release being performed, resecting the scarred rotator interval capsule. Risks of surgery include fracture of the humerus or even dislocation of the shoulder due to overzealous capsular release or releasing at the glenoid labral junction, which can result in dislocation. Also, be wary of the neurologic structures, specifically the axillary nerve, when releasing the capsule at the 6 o'clock position. Most of us will release the anterior capsule and the posterior capsule and then gently manipulate the arm so as not to directly excise capsule at the 6 o'clock position in order to avoid injury to the axillary nerve, which can lie as close as 12.5 millimeters from the inferior glenoid. Postoperative rehabilitation. It's important to coordinate this before the surgery so that everything is in order. So when the patient is discharged from the ambulatory surgery facility, you can begin physical therapy immediately. I typically begin physical therapy that very same day, taking advantage of a long-acting interscaling block or indwelling interscaling catheter. In the past, intra-articular glenohumeral catheters were used to infuse local anesthesia into the joint. These have been abandoned due to complication of condylolysis. The number one complication associated with this condition in surgery is residual or recurrent loss of motion. It's important to advise patients of that even if they do have successful surgery, if they're not compliant with the physical therapy or they don't work hard postoperatively, their stiffness will continue. And in general, diabetics have worse outcomes compared to other groups of patients. Question. A 47-year-old female with no history of trauma has a painful, stiff shoulder for 3 months. Treatment consisting of a subacromial cortisone injection and anti-inflammatory medication has been ineffective. Active range of motion of the shoulder is painful and includes 60 degrees of forward elevation, internal rotation to the sacrum, 30 degrees of external rotation. Plain films are normal. Treatment should consist of A, arthroscopic capsular release, B, manipulation under anesthesia, C, physical therapy, D, intra-articular corticosteroid injection, or E, high-dose oral corticosteroids. The answer is C, physical therapy, again, the mainstay of treatment. Question. A 52-year-old female presents with a 6-month history of atraumatic left shoulder pain and limited range of motion. Physical examination reveals global loss of active and passive range of motion. X-rays are normal. MRI scan reveals an intact rotator cuff. The etiology of this clinical condition is thought to be related to A, crystal arthropathy, B, autoimmune process, C, infectious process, D, fibroblastic process, E, chondrocytic process. The answer is D, fibroblastic process. Histologically, adhesive capsulitis is due to a fibroblastic proliferation and collagen deposition. Os acromial. Os acromial refers to an unfused secondary ossification center. It is bilateral in 60% of cases. Most common location is at the junction of the meso and metaacromion. The key to diagnosis is the axillary X-ray or axial MRI cuts, as you can see here. Majority of patients with os acromial are asymptomatic. It seems to be associated with impingement and rotator cuff tears. If it is sufficiently symptomatic to warrant surgery, in general, you want to avoid excising the lesion because that may lead to deltoid or deltoid dysfunction. An arthroscopic subacromial decompression should also be avoided, as that will potentially destabilize the os acromial. The The surgery that's preferred is open reduction and internal fixation, usually with some type of autogenous bone graft. Complications of this operation include non-union, persistent shoulder pain, and stiffness. Question: a 22-year-old male presents with shoulder pain. Radiographs are shown. What is the most likely cause of pain? A, acute acromial fracture. B, a type 4AC separation. C, deltoid avulsion. D, failure of fusion between the meso and preacromion. Or E, failure of fusion between the meso and metaacromion. Answer is E, failure of fusion between the meso and metacromion. This is the most common form of a symptomatic os acromial. Pectoralis major. Two portions to the pectoralis major muscle, the clavicular or superior half and the sternal or inferior half. Both muscle portions will converge, rotate 90 degrees prior to inserting as a single tendon on the proximal humerus. The tendon is 7 centimeters long, but only 2 millimeters wide. The muscle receives innervation from the medial pectoral nerve, which innervates both the clavicular and sternal heads, and the lateral pectoral nerve, which innervates the sternal head only. Muscle functions as a powerful internal rotator and adductor of the humerus. It also has a role in flexion of the arm. Injuries occur during the eccentric phase of muscle contraction. The classic mechanism of injury is a bench press exercise. Patients will experience a pop in their chest wall with associated ecchymosis and deformity of the muscle. You want to distinguish between pure muscle injuries and tendon avulsion injuries. With the latter, there will be webbing of the skin involving the axillary fold, so you'll lose the normal contour of the inferior axillary fold, and this is assessed with the arm in abduction. You may also see a dropped nipple sign where the affected the nipple on the affected side sits lower than the unaffected side. Ordering the correct MRI scan is very important. When patients come in with a suspected pec rupture, you want to order an MRI of the chest wall as opposed to an MRI of the shoulder. The cuts won't be distal enough to assess the pec in a standard shoulder MRI, so you want to get an MRI of the chest wall. MRI is very helpful in distinguishing between pure muscle injuries and tendon avulsion injuries. You can see here the classic appearance of a tendon avulsion. Here is the retracted tendon. The yellow arrow is pointing to that, and with the humerus here. So several centimeters of medial retraction. Non-operative treatment is really reserved for pure muscle injuries, partial tears, and those chronic tears that are asymptomatic. For distal tendon ruptures, these should be repaired within the first 6 weeks, and it is a tendon-to-bone reattachment. Suture anchors have been used, buttons, transosseous sutures, but it is a tendon-to-bone repair. Beyond 6 weeks, the good news is that the majority of these can still be managed with primary repair. The Muscle does not retract very much. It is usually very well mobilized, and a primary repair can still be achieved even in more chronic injuries. But it is advisable to at least have allograft available should you not have enough length. Postoperatively, patients are maintained in a sling for 4 to 6 weeks with gentle Codman exercises only. You want to avoid any early active abduction, flexion, and external rotation, which would place stress on the repair. Active range of motion exercises are initiated at 6 weeks, and strengthening of the pec muscle is delayed for 3 months. Question: during a bench press exercise, when is the pectoralis major insertion at greatest risk for rupture? 1. Initiation of upward motion. 2. Point of maximum elevation. 3. During downward deceleration. 4. When the bar is touching the chest. Or 5. No difference in rupture rate is seen. The answer is during downward deceleration. This injury most commonly occurs when the weight is taken down and there is eccentric contraction of the muscle during the braking motion, and this will prevent the weight from falling down. So it's during downward deceleration, during eccentric contraction of the muscle. Proximal biceps tendon. It's important to recognize that pathology involving the long head of the biceps tendon typically does not occur in isolation. It is often, or pathology of the bicep tendon is often associated with other pathology around the shoulder. The coracohumeral ligament, rotator interval, may be torn along with the anterior portion of the supraspinatus tendon. We all know classically subscapularis tendon tears can lead to biceps tendon instability, irritation, and hypertrophy. So again, it's unusual for patients to present with isolated pathology of the biceps tendon. You can see here these axial cuts on the left. You're seeing a intact subscapularis tendon and a normally located biceps tendon in the bicipital groove. On the right, you see a ruptured biceps tendon along with a medially dislocated biceps tendon. So a ruptured subscap with a medially dislocated biceps on the right. Different types of pathology to the biceps tendon have been described. You can have the classic lipstick lesion, which refers to inflammation along the biceps. You can see that when you do a arthroscopy of the glenohumeral joint. You'll see hyperemia along the base of the biceps extending along its course. Tearing of the biceps. You can see here how frayed and torn this biceps tendon is. And instability of the biceps associated, as I said, with ruptures of the subscapularis, rotator interval, and the anterior portion of the supraspinatus tendon. And then you can have instability of the superior biceps labral anchor complex or an unstable slap lesion. For all of these conditions, if you feel that the biceps is a source of symptoms, these are treated either with tenotomy or tenodesis. Diagnosing biceps tendon pathology is highly subjective. Patients may present with pain about the anterior aspect of their shoulder. There may be tenderness to palpation over the bicipital groove. Various provocative tests or biceps tension signs have been described. These, unfortunately, are not very specific. You can consider doing a targeted diagnostic lidocaine injection and assessing patient's response to help further hone in on the diagnosis and the biceps tendon as a source for patient symptoms. Tenotomy can lead to a Popeye or cosmetic deformity. It can lead to residual cramping. There has been a modest loss of supination strength associated with this procedure. In general, it is well tolerated, especially in elderly, lower demand individuals, but it has been shown to yield reliable pain relief. Advantages of tenodesis is that it helps prevent the Popeye deformity and cramping. Better suited for younger, active individuals, preserves muscle strength, and various techniques have been described. Soft tissue tenodesis procedures, tenodesis proximal to the bicipital groove, and subpectoral tenodesis. In terms of the literature, when comparing tenotomy versus tenodesis, no definitive clinical difference in anything except cosmetic deformity. So, clinical functional outcome studies, no difference between tenotomy or tenodesis. Question. In addition to an arthroscopic debridement of the joint for an irreparable rotator cuff tear, what will a simple biceps tenotomy most likely produce? A. Glenohumeral arthritis. B. Pseudoparalysis of the arm, likely needing a reverse total shoulder arthroplasty. C. Potential satisfactory pain relief. D. A Popeye deformity and significant strength deficit. E. Superior migration of the humeral head. And the answer is potential satisfactory pain relief. I think the key term here in these questions in D, in choice D, was significant strength deficit. It should not lead to a significant strength deficit. So that's why I believe choice C is the better answer. Rotator cuff tears and impingement syndrome. Rotator cuff anatomy. You should be aware of the footprint attachment sites of the various tendons. Supraspinatus footprint is triangular in shape compared to the infraspinatus footprint, which is more rectangular in shape and much larger. So the infraspinatus footprint much larger than the supraspinatus, and it is rectangular in shape compared to the more triangular or trapezoidal shape of the supraspinatus footprint. Subscapularis footprint being the largest. And you see the teres minor footprint posteriorly here. The footprint of the supraspinatus is confluent with the articular margin. Supraspinatus function is that it initiates abduction and works synchronously with the deltoid. The concavity compression phenomenon of the two muscles working together prevent proximal humeral head migration. It is the most commonly torn rotator cuff tendon. The infraspinatus frames the bare area. You can see that arthroscopically. It functions as a primary external rotator. It's tested with the arm in adduction, and it's the second most commonly torn rotator cuff tendon after the supraspinatus. Subscapularis footprint is the largest, inserting on the lesser tuberosity, adjacent to the bicipital groove and biceps tendon. Its fibers blend superiorly with the coracohumeral ligament and rotator interval. It is the strongest of the four muscles and acts as a primary internal rotator. Tests for subscapularis integrity are the liftoff test, belly press test, and assessing for an internal rotation lag sign. The four tendons of the rotator cuff are each made of multiple layers of collagen. The most common type is type 1 collagen. However, where it inserts onto the footprint, this is transitions to fibrocartilage and type 2 collagen. Functionally, with large rotator cuff tears, large supraspinatus tendon tears, you will lose that concavity compression phenomenon, and that's when you'll have obligate superior humeral head migration as the arm is abducted. You no longer have the compressive force of the supraspinatus, and the humeral head will migrate proximally. Partial thickness tears, you want to assess the degree of tearing. Typically, for those tears that are involve less than 50% of footprint compromise. These are typically treated with debridement. Articulosided tears are much more common than bursal-sided tears. This is a bursal-sided tear that you can see on your right. You see the articular fiber is still attached, but the bursal fiber is disrupted. Be familiar with the term posta lesion, which stands for a partial articulosided supraspinatus tendon avulsion. Again, if more than 50% of the footprint is compromised, repair is the preferred treatment. Full thickness tear patterns. You have the classic crescent-shaped tear on the left, and then the middle is the U-shaped tear, and then the L-shaped tear on the right. U-shaped tears and L-shaped tears in general require some type of side-to-side or margin convergence suturing in addition to tendon-to-bone repair. Natural history. Prevalence of these tears is age-dependent. Patients 60 to 80 years old, 25% will have full-thickness rotator cuff tears. Beyond 80 years of age, 50% of patients will have full-thickness rotator cuff tears. Fortunately, many are asymptomatic. With progression from asymptomatic to symptomatic tears, typically this is associated with increase in tear size, decrease in muscle quality, or better said, advancement of muscle atrophy, and increase in pain. So these are signs associated with progression from being asymptomatic to symptomatic. So the tear will get bigger, the muscle become more fatty, and you'll have an increase in pain. It is not related, however, to age or gender, so older patients don't necessarily have a greater chance for progression from asymptomatic to symptomatic. Larger tears are more likely to become symptomatic. So if you have a larger tear to begin with, likelihood is that these tears have a higher likelihood of becoming symptomatic. Again, supraspinatus tendon tears are the most common. They represent 60% of all rotator cuff tears. Cuff tear etiology. You have the classic intrinsic causes originating within the tendon due to repetitive microtrauma and overload. Biologic causes, aging, avascularity, change in the type of collagen, and shear forces across the tendon, and extrinsic causes or external compression on the coracoacromial arch, although recent literature has called into question the classic outlet impingement, which has likewise called into question the need for acromioplasty. More on that in a few moments. Shoulder dislocations. Beware of patients who are older, who dislocate their shoulder and have significant weakness on physical examination. In those patients, you should assume that there is some type of concomitant injury to the rotator cuff until proven otherwise. So those patients probably should be further evaluated with some type of advanced imaging, either MRI or ultrasound. If they're under 40 and have significant weakness after a dislocation, be wary of the possibility of concomitant injury to the axillary nerve. Cuff evaluation. History. Patients classically come in with pain and more specifically night pain. Physical examination, you want to assess the AC joint for tenderness and for pain with cross-chest adduction. Classic impingement signs, Neer and Hawkins, biceps tension signs, Speed, Jurgensen. You want to isolate the individual muscles, assessing for weakness and lag signs. Appropriate radiographs, including an outlet view, looking at the coracoacromial arch. and an MRI scan to assess for muscle quality and tendon retraction. You can see here the classic appearance on the left of a partial thickness rotator cuff tear and then a full thickness rotator cuff tear on same type of sequence imaging on the right. Treatment indications. So indications for surgery: acute traumatic rotator cuff tears should be repaired. Symptomatic high-grade partial thickness rotator cuff tears that have failed non-operative treatment, and more chronic symptomatic full thickness rotator cuff tears that have also failed non-operative treatment. Contraindications for surgery: asymptomatic tears. So we are not fixing asymptomatic rotator cuff tears. Certainly irreparable tears with more advanced atrophy. Older patients, I would argue with you that that's more of a relative contraindication for surgery. I think more and more we are not holding or withholding surgery on older patients based upon their chronologic age. I think this is more of a physiologic age determination. Patients with glenohumeral arthritis and patients with certainly signs of irreparable tears like anterior superior scape or pseudoparalysis. Those are patients that would not do well with attempted repair. Non-operative treatment: physical therapy, anti-inflammatory medication, cortisone injections. A couple of words about cortisone injections. You should be aware of recent literature that has called concern or raised concern regarding giving injections close to the time of surgery. Injections given within 1 month of surgery have been associated with higher infection and revision rates. So be wary of patients who come to see you who have had a recent cortisone injection, and certainly reconsider giving cortisone injections on patients that you may consider operating on in the near future. Surgery, we are obviously trying to do repairs or at least partial repairs for rotator cuff tears, for those tears that are irreparable, that patients still are requiring surgery because of symptoms. You can consider doing a simple scope debridement with biceps tenotomy or tenodesis with a possible tuberoplasty of the greater tuberosity. Tendon transfers, I'll talk about that in a moment. Superior capsular reconstruction. More recently, balloon arthroplasty, putting in a balloon spacer in the subacromial space, has shown some promise. And for older patients with irreparable rotator cuff tears and weakness, reverse total shoulder arthroplasty. A few words about latissimus transfers. Indications are irreparable tears in young patients, no arthritis, and a functioning subscapularis muscle. That's the key thing. That's the testable question here. Surgical treatment for partial thickness rotator cuff tears. Again, we talked about debridement for tears that involve less than 50% of the footprint and repair for those involving more significant footprint compromise. Full thickness rotator cuff tears. The answer is repair, especially for acute tears in young patients with symptoms. But also, as I mentioned before, older patients based upon their physiologic level of activity. Non-operative treatment for full thickness rotator cuff tears in general for older patients, patients with chronic full thickness rotator cuff tears and preserved function. These are tears that you should consider treating non-operatively. Surgical approaches: open, mini-open, arthroscopic, all acceptable forms of treatment here. One What about acromioplasty? Recent AOS guidelines have indicated that routine acromioplasty is probably not necessary when performing a rotator cuff repair. Biggest complication or most frequent occurrence is recurrent tear, or really probably non-healing of the tear. Also stiffness and infection. Beware of P. acnes. Labs must be kept cultures must be kept for at least 21 days to rule out P. acne infection. What about distal clavicle excision for patients with concomitant AC joint related pain? So we are not operating here on AC joint arthritis by X-ray. We are operating, if we are doing a distal clavicle excision, on patients with symptomatic AC joint arthritis. So you want to assess for anterior superior pain, tenderness to palpation over the joint, pain with various maneuvers, cross-body adduction, the active compression test, and you can do a targeted lidocaine injection test to assess for the AC joint as being a source of symptoms. Imaging. So again, as I said, we're not recommending surgery based solely on X-rays or the MRI scan. It is important to point out that recent randomized controlled trials have called into question even doing a distal clavicle excision, even in patients who have tenderness to palpation over their AC joint and a positive lidocaine injection test. There was a recent randomized controlled trial looking at patients who had all of these symptoms, including the positive lidocaine injection test. Half of them had distal clavicle excisions, the other half did not, and both groups did exactly the same. So I think we ought to think twice about doing a distal clavicle excision based upon the recent clinical studies. It's important when thinking about surgery for patients with rotator cuff tears to do a thorough preoperative assessment to assess for whether or not these tears are repairable or irreparable. Irreparable tears being those with higher grades of fatty atrophy, diminished acromiohumeral interval, patients with escape or pseudoparalysis. What about single versus double row? Biomechanical studies have certainly shown that double row repairs are stronger with less gap formation, increased footprint compression and coverage, increased energy to failure, and increased resistance to shear stress. However, clinical studies have shown no difference in functional outcome or re-tear for small and medium-sized tears when comparing single row versus double row repairs. So current AOS guidelines, acute traumatic rotator cuff tears, the answer is repair. Asymptomatic full thickness rotator cuff tears, the answer is no surgery. Symptomatic full thickness rotator cuff tears, rotator cuff repair is an option for chronic symptomatic full thickness rotator cuff tears, and routine acromioplasty not required. Postoperative rehabilitation is pretty conservative in my hands. For large and massive tears, we'll immobilize them in a sling for 6 weeks, and we won't begin physical therapy until after that. For small and medium tears, we'll utilize a sling for 6 weeks, and it's important to point out that there has been no difference between early versus delayed PT, even in small and medium-sized tears. If you delay PT, you may have a little bit of stiffness or loss of motion early on, but when you assess them at final outcome, both groups did the same. Active range of motion exercises are delayed until beyond 6 weeks, and cuff strengthening is delayed until 10 to 12 weeks postoperatively. Do rotator cuff tears heal? Unfortunately, many do not. The failure rate is kind of all over the board depending upon who you read. Best predictors of whether tears are going to heal are number one, size. Larger tears have a higher failure rate, chronicity, and age of the patient. Calcific tendinitis. Etiology is unknown. This condition involves deposition of calcium hydroxyapatite crystals. It is a self-limited condition, most commonly involving the supraspinatus tendon. 3 stages: pre-calcific, calcific, and post-calcific. Calcific stage broken down into the formative process, resting process, and then finally the resorptive process. This is the process that involves phagocytic resorption of the calcium, and it is classically associated with severe shoulder pain. Non-operative treatment is recommended. Initially, you can administer a subacromial cortisone injection. Extracorporeal shockwave therapy has been shown to work in some cases. Here at NYU, we're doing a lot of barbotage of the lesion under ultrasound guidance. Radiologists will target the lesion with a needle and then flush it out and inject it with local anesthesia. So that's been shown to be effective as well. For those patients that fail non-operative treatment, surgery has been shown to be successful, especially for those with larger deposits, those patients with multiloculated deposits involving different tendons, patients with continued pain despite non-operative treatment, and the treatment is arthroscopic debridement with or without rotator cuff repair. Remember, to get at the lesion, you do need to incise the rotator cuff and remove the calcium deposit, liberate the calcium from the cuff. That will leave a defect in the cuff. If it's a significant defect, you may want to consider doing a repair of the incision in the cuff. Question: at her 6-week visit after arthroscopic rotator cuff repair of a full-thickness rotator cuff tear, patient has not yet attended physical therapy. Which outcome at 1 year is expected? Persistent stiffness resulting in loss of range of motion. 2, high likelihood of needing a capsular release. 3, improved rotator cuff healing despite persistent stiffness. 4, no long-term difference in motion compared to early PT. And 5, significant decrease in functional outcome compared to early PT. Answer is 4, no long-term difference in motion compared to early PT. So early therapy is beneficial only to improve early range of motion. At 1 year, you'd expect no difference between early and delayed PT. Question: 55-year-old female complains of right shoulder pain for 5 days, which keeps her up at night. She states that pain is in her shoulder. Physical examination reveals positive impingement signs, decreased range of motion, and weakness. Treatment: 1, steroid injection and PT. 2, arthroscopic capsular release. 3, MRI. 4, manipulation under anesthesia. 5, Brisemont procedure. The answer is 1, cortisone injection and physical therapy. This is a patient presenting acutely with just 5 days worth of symptoms. So you want to be conservative. Question: a patient is unable to actively externally rotate the shoulder when the arm is placed at 90 degrees of abduction and neutral rotation. This finding is most consistent with a tear of the 1, biceps tendon, 2, isolated subscapularis tendon, 3, isolated supraspinatus tendon, 4, superior and inferior labrum, 5, infraspinatus and teres minor. Answer is infraspinatus and teres minor. So patient has a positive hornblower sign. You're assessing for external rotation in abduction. That's a hornblower sign. That lesion involves the teres minor. Question, which risk factor is most commonly associated with cuff non-healing after repair? 1, smoking status. 2, age greater than 65 years. 3, smaller cuff tears. 4, early repair of acute tear. 5, workers' compensation claim. So which risk factor is most commonly associated with cuff non-healing? Answer is age, greater than 65 years. None of those other items listed there would be associated with non-healing other than smoking status, but age is more important. Subscapularis. Tears of the subscapularis, unfortunately, are often missed. Clues would be tears involving the anterior portion of the supraspinatus tendon, which can also involve the rotator interval, thereby leading to, thereby being associated with more anterior lesions, including the subscapularis and biceps dislocation. So these are the clues to having involvement of the subscapularis. Tear involving the anterior portion of the supraspinatus tendon and a biceps dislocation. Also, by history, be wary of patients who've had previous open surgery where the subscapularis was taken down and then repaired, who then fall on an outstretched hand, have some kind of trauma, and patients with who dislocate their shoulders. Physical examination, increased passive external rotation at the side. You can see that there. Positive belly press test, positive liftoff test, and positive internal rotation lag sign. Axial images on MRI scan begin at the coracoid process and then work distally, and you'll see the rupture of the subscapularis, which you see there, and a perched biceps tendon on the lesser tuberosity. These patients, again, will often have concomitant tears involving the anterior portion of their supraspinatus tendon. Treatment, repair, either open or arthroscopic, with a biceps tenodesis or tenotomy. Corticoplasty can also be performed if you feel that there is a diminished subcoracoid space, but that's somewhat controversial. Question, 23-year-old football player, contact injury to the shoulder in external rotation. So think about arm position, immediate pain, internal rotation weakness, increased external rotation, positive liftoff test, treatment, 1, inferior capsular shift, 2, pectoralis major repair, 3, open Bankart repair, 4, acromioplasty, 5, subscapularis tendon repair. Answer 5, subscapularis tendon repair. Question, 25-year-old carpenter falls on an outstretched arm. What physical examination finding best correlates with the lesion on the MRI? 1, weakness in external rotation. 2, weakness in abduction. 3, positive lift-off test. 4, loss of biceps contour. 5, deltoid atrophy. Answer 3, positive lift-off test. Question, which of the following is the most important restraint to medial instability of the biceps? 1, subscapularis tendon. 2, coracohumeral ligament. 3, superior glenohumeral ligament. 4, morphology of the bicipital groove. 5, origin of the long head of the biceps tendon from the supraglenoid tubercle. Hopefully you all picked subscapularis tendon as being the most important restraint to medial instability of the biceps.